Okay.
Distinguished guest and respected audience, good evening and Assalamu alaikum. I am Dr. A.K.M. Ziaul Haq, Vascular and Endovascular Surgeon. I welcome you all to the webinar organized by SINA Hospital. Today, our presentations and discussions will evolve around varicose vein. Our keynote speakers and distinguished panelists will deliver their valuable insights on modern management of varicose vein. This webinar is also live on Facebook pages, so you can watch it from Facebook. You can put your questions in comment boxes. Don't forget to invite and share this program with your family members and friends. Today, we are honored by the presence of our beloved mentor, international faculty, freedom fighter, and vascular and endovascular surgeon, Dr. M. Abidur Rahman from New York, USA. Mr. Abidur Rahman sir, Dr. Abidur Rahman sir is the chairperson of today's webinar. We have two respected vascular surgeons as panel of experts for this live webinar program. First, Dr. J.M. Mokbul Hussain, Honorary Chief Vascular and Endovascular Surgeon, Vascular Care Center, Ibn Sina Hospital. Second, we are also honored by the presence of Professor Dr. Noyesh Chandra Mondol, Professor and Head of the Department Vascular Surgery and ICBD. We have two keynote speakers. First presentation will be delivered by Dr. Rakibul Hassan, Assistant Professor, Vascular Surgery, Bangabandhu Sheikh Mujib Medical University. His topic is Modern Intervention for the Treatment of Varicose Vein. Second presentation will be delivered by the Swadesh Ranjan Sarkar, Assistant Professor, Vascular Surgery Department, NICBD. His topic is Varicose Vein Treatment by Superglue, VENASEALT without anesthesia. Now I request Dr. J.M. Mokbul Hussain sir to deliver inauguration for this webinar. Dr. J. Mokbul Hussain sir, please.
Assalamu alaikum. Welcome all of you to today's webinar. We are really delighted to your presence in this webinar. Varicose vein is a worldwide venous problem. Around 20 to 30% of the population suffer from varicose vein. Some study also says a large population suffer from this disease. So patients are not sometimes well aware of this problem. And the patients move from door to door. Sometimes it is told that the real treatment or exact treatment is not available in our country. What happens in our country, there is a lot of patients, but patient is not understanding the problem bulk, and sometimes the doctors are not, what is this, and is this treatment is available in this country or not. So some sort of confusion arises between this doctor group as well as the, so awareness is needed among the doctors as well as the patients also. আমরা যেন বলতে পারি যে না এই রোগটা একটা কমন প্রবলেম এই দেশে আছে, সাইমালটেনিয়াসলি এটা ট্রিটমেন্ট অ্যাডভান্স ট্রিটমেন্ট যা ওয়ার্ল্ড ওয়াইড আছে, that is also available in our country. We can tell like in such a way. So patients move from door to door. By this time complication happening, there is thickening, blackening, and also ulcer. Last century, the century was surgery for varicose vein. That the operation was the only treatment. But at the starting of this century, the trend has changed. Now surgery has changed to endovascular, that is the endovenous intervention. So we will learn about this from today's webinar. With these few words, I like to share all our audience as well as our respected mentor and our sir, Dr. Abidur Rahman, he is with us. Sir, অনেক বছর যাবত এই যে ভাস্কুলার সার্জারি স্যার আমরা আজকে যারা এখানে আসি এই অবদানটা স্যারকে দিয়েই আমাদের প্রোগ্রাম শুরু করতে চাই যে স্যার আপনার হাত ধরে আমরা শিখছিলাম যে ভাস্কুলার সার্জারির সঙ্গে এন্ডোভাস্কুলার সার্জারি আমরা শুরুতে ভাস্কুলার সার্জারির সঙ্গে এক্সপোজ ছিলাম, বাট উই ওয়ার নট এক্সপোজড উইথ এনি সর্ট অফ এন্ডোভাস্কুলার সার্জারি। স্যার আপনি যে আশা শুরু করলেন তারপর এবং আপনি বললেন যে একটা ভ্যাকুয়াম আছে এন্ডোভাস্কুলার সার্জারি বাংলাদেশ, রিয়েলি ওই জায়গাতেই আমরা সেখান থেকে দেখলাম যে সত্যি আমরা শুরু করছিলাম, এখন অ্যারাউন্ড 70 to 75% কিন্তু আমরা স্যার এন্ডোভাস্কুলারে আমরা টার্ন নিতে পারছি, রেস্ট অফ দ্য কেসেস ওপেন ভাস্কুলার সার্জারি। আমার মনে হয় উইথ দিস ফিউ ওয়ার্ডস ডক্টর জিয়া, you can
Yes, sir.
start the speakers.
Yes, sir. Thank you, sir. Thank you, sir, for your innovation speech. Now we would start our presentation. I would like to request Dr. Rakibul Hassan Opu, Assistant Professor Vascular Surgery, Bangabandhu Sheikh Mujib Medical University, to deliver his speech on modern intervention for the treatment of varicose vein. Dr. Rakibul Hassan Opu,
Yes,
please.
Dear learned audience, respected teachers, and my dear colleague, Assalamu alaikum. I am Dr. Rakibul Hassan Opu, Assistant Professor, Department of Vascular Surgery, Bangabandhu Sheikh Mujib Medical University. Welcome you all to this webinar session. And today's topic, the modern intervention for the treatment of varicose vein. First of all, about the understanding of chronic venous disorder. This is the clinical classification for chronic venous disorder. C1, telangiectasia or reticular veins. C2, varicose veins. C3, edema. C4A, pigmentation or eczema. C4B, lipodermatosclerosis or atrophic bands. C5, healed venous ulcer. And C6, active venous ulcer. Treatment modalities. The current treatment modalities, the conservative therapies, example, exercise, leg elevation, compression stocking, use of NSAIDs, antibiotics according to culture sensitivity, and for venous ulcer, 4-layer bandage. And treatment options for venous insufficiency, the thermal and tumescent, 2 options, endovenous laser ablation and radiofrequency ablation. Non-thermal and non-tumescent, mechanochemical ablation. Non-thermal, non-tumescent, and non-sclerosant, that is VENASEALT system, and other is surgical stripping. Conventionally, the saphenous vein trunk is removed by open surgery using a vein stripper. Incompetent perforator is ligated, and varicosities are removed by phlebectomy. This is the new update about the treatment option of venous disease in 2020. By American Venous Forum and Society of Vascular Surgery.
Anything wrong, Opu?
Sir, technical difficulty is. Hang. Okay. The varicose vein treatment using the radiofrequency ablation. Indications, the symptomatic patients, the varicose vein with complications and cosmetic grounds. The RFA, radiofrequency ablation, it is an endovenous procedure. RFA catheter used for vein ablation, generation of heat by heating segments, and damage of endothelial lining by heat. And this is the closer first system procedure, radiofrequency ablation by Medtronic. And equipments, first of all, we need the radiofrequency ablation machine. This is the machine. Then radiofrequency ablation catheter. The catheter has 3 components, handle, shaft, and heating element. And this is the handle. It got 3 parts, the button to start or stop the treatment within the sterile field, lower port for flushing and guide wire, and another integrated cable to generate heat. And this is the thermocouple or heating element. The radiofrequency energy to provide an even and uniform heat to contract the collagen in the vein walls, causing them to collapse and seal the vein closed. And other equipments, we definitely need the ultrasonogram machine. the puncture needle, guide wire, and 7 French sheath, because the hidden element is 7 French in dia. And this is the video clips of radio frequency ablation. We put a sheet, and through sheet we introduce the RFA catheter 2 centimeter away from the sacrophumeral junction, and we start the to produce the energy, and catheter to hit a 7 centimeter vein length in 120-second interval, and after each segment is treated, the catheter is repositioned to the next segment, and the process is repeated until the entire length of the disease vein has been sealed. The catheter is repositioned and every segment is ablated. And this is the mark of the catheter. It is 6.5 centimeter in length. An entire length of the disease vein has been sealed. And this is the varicose vein, bilateral varicose vein. And for when we start the radiofrequency ablation procedure, first of all, we mapping the great saphenous vein. And this is the picture of introduction of puncture needle. And we put the guide, introduce the guide wire. Then we put sheath. And after introduction of the RFA catheter, we give the tumescent fluid. Sometimes we can also give the tumescent anesthesia if general anesthesia and spinal is not given. And this is the introduction of tumescent anesthesia. This is the perivenous collapse. And tumescent anesthesia preparation. This mixture is injected around the perivenous space of great saphenous vein. Composition 50 ml 1% lignocaine with adrenaline, 450 ml normal saline, 10 ml 8.4% sodium bicarbonate. Purpose: the local anesthesia to make collapse of great saphenous vein, better contact of heating part of radiofrequency ablation catheter with endothelium, and to protect surrounding tissue from heat damage. And after RFA, we give the sclerosing agent into the varicosities, and mostly we use the STS, sodium tetrahedral sulfate, and this is the preparation of foam sclerotherapy. And after sclerotherapy, we applied the crepe bandage. And this is the picture, shows the before RFA procedure or varicose vein and after RFA procedure. Contraindications of radiofrequency ablation. The great saphenous vein too close to skin, hugely dilated great saphenous vein more than 25 millimeter, too tortuous great saphenous vein, chronic thrombophlebitis of GSV, acute thrombosis of GSB. Complications: bluish vessel perforation, hematoma, infection, skin pigmentation, paresthesia, damage to non-target tissue, and skin burn. And there is another option, it's called mechanochemical ablation. It is a non-thermal and non-tumescent option, no need of thermal energy or tumescent. The endothermal techniques require the use of tumescent anesthesia to neutralize the heat produced during treatment. Tumescent anesthesia is associated with patient discomfort. Also, heat-related complications like skin burn, paresthesia, and prolonged post-procedural pain are experienced. Searching for a new technique to minimize the negative effect of endothelial ablation, a method to occlude the varicose vein in a mechanochemical way was introduced. Device. There's two device, Clarivein system and Flevogrip system. In our country, we started with Flevogrip system. And equipment, we definitely need the ultrasonogram machine. And here the puncture needle, the sheath, and guide wire. And this is the mechanochemical ablation catheter, this Flevogrip. In the tip, it has the two cutting element and a port for sclerosing agent. aim, they scratch the endothelium during catheter movement and simultaneous delivering the sclerosing agent to ablate the varicose vein. No anesthesia, no hospitalization required. And this is the step. First of all, we puncture the great saphenous vein by ultrasound guided puncture. Then we introduce the guide wire, and then we introduce the sheath, and through sheath we introduce the phlebogrip catheter, mechanochemical catheter, and the tip is placed 2 cm away to the saphenofemoral junction. This is the release of cutting element, and we slowly pull back, and the sclerosing agent is given behind, and after all, compression therapy is given. And this is a video clip of phlebogrip. This is the wire at the saphenofemoral junction. Then the tip is placed 2 cm away from the saphenofemoral junction. Then wire is removed, the cutting element, and we give the sclerosing agent, and gradually the vein is collapsed. Advantage: the heat-related complications like skin burn, paresthesia will not appear. The less post-procedural pain compared to thermal ablation, faster recovery, no deep venous thrombosis and pulmonary embolism. Disadvantage: superficial thrombophlebitis may occur, hematomas, and skin inflammation. The home message: the most pivotal outcome of varicose vein treatment should be the clinical outcome. The clinical outcomes that are significant for patients include the relief of symptoms, improvement in quality of life, prevention of ulceration, and satisfaction with aesthetics. RFA and mechanochemical ablation is a safe, feasible, and effective treatment in abolishing saphenous reflux. Thank you all.
Thank you. Thank you, Dr. Rokibul Hassan Opu, for your nice presentation. Now I request Dr. Swadesh Ranjan Sarkar, Assistant Professor, Vascular Surgery Department, NICVT, Dhaka, to deliver his speech on varicose vein treatment by superglue VENASEALT without anesthesia. Dr. Swadesh Ranjan Sarkar, please.
Good evening, sir.
Good evening.
Good evening.
Yes. So this is Dr. Swadesh Sarkar, vascular and endovascular surgeon. Welcome you all to today's CME on modern treatment modalities of varicose vein. Now I am presenting my presentation on non-thermal superglue VENASEALT treatment for varicose vein. And there are my previous presenter already mentioned different modalities of treatment: thermal, surgical, thermal, and non-thermal ablation. And I am going to present VENASEALT closure system that is marketed by Medtronic. And this picture showing the different equipments of VENASEALT here. And we need in packet there is a 5 cc vial, 5 cc vial of VENASEALT glue, and dispenser, 1 dispenser gun, 7 French into a sheath, 5 French delivery catheters, 5 French dilator, 3 cc 3 cc syringe, and 14 gauge dispensing tip, 035 180 J tip guide wire. And why we are said this is the ideal glue, that is the cyanoacrylate glue for chronic venous insufficiency. We need to be viscous in order to prevent migration, needs to polymerize quickly, and needs to be soft and elastic, and must be strong enough in order to prevent recanalization. And here is the VENASEALT animation showing a video animation of VENASEALT. introduction of VENASEALT system with dilator, and here we have to put 5 centimeter from saphenofemoral junction, and glue is delivered by pushing of gun, and we have to ensure by pressing ultrasound probe to ensure the sealing system by applying glue. Repeat 3 centimeter apart from, and each time we have to deliver it for 3-second glue, and amount of glue is 0.1 cc. And absolutely it is an office-based procedure. There is no need for anesthesia. Patient have to leave hospital same day of procedure, just after 3 to 4 hours, doing the non-thermal glue ablation of varicose vein. And for VENASEALT ablation, we have to follow some basic steps. This is venous access. All types of endovenous ablation, we need to venous access by image guided, that is ultrasound guided puncture of the GSB, and insertion of introducer sheath, preparation of gun with glue, and delivery of glue within the vein. And here is another video on live. This is the package system of VENASEALT. It is about in Bangladeshi Dhaka, it is 90,000 per packet. I think in USA 750 and $800 US dollar. And here are the different equipment. Two types of catheter. This is flushable, and another is non-flushable equipment. I can again stop here. One is non-flushable component, and another is this is non-flushable dry. So we have to prepare two different trolley. One must be kept dry with a separate team. They will prepare the gun system. And this is the GSB mapping in standing position before puncture of before access of great Stephanus vein. Here we see the in axial cut, the diameter of GSB. Usually, we prefer below knee puncture, and marking is done here below knee GSB. Local anesthesia, lignocaine is infiltrated. And this is the micropuncture needle. Under ultrasound guidance, GSB puncture is going on. And 1H guider is introduced with the microaccess sheath and dilator into the gracious GSB, gracious vein. And later on, O35 guider is introduced. This is the cephalohumeral junction. If O35 guider is negotiated into up to GSB, cephalohumeral junction, and remove microaccess reference sheath for confirming position of O35 guider into cephalohumeral junction. We introduce the dilator. It is blue in color. Flashing the lumen of introducer, blue introducer. And one, this is the key point here in RFA and laser, and also in mechanochemical ablation, usually put 2 to 3 centimeter tip is landing 2 to 3 centimeter apart from cephalohumeral junction. Here we have to put the catheter tip 5 centimeter away from the cephalohumeral junction. And this is the dry, that is non-flashable component. Blue is taken into 3 centimeters. Yeah, there is air free. Did it air free. This is the glue delivery catheter, VENASEALT delivery catheter, and this is preparing for delivery of glue into gun. Here we have to trigger up to terminal marking, laser marking. This is showing the glue is negotiated by pushing gun. And now it is inserted into the dilator. For positioning, we have to pull back. That is 5 centimeter apart from the cephalohumeral junction. And here it is, glue is attached with gun, dispenser gun. This is a very, very important step. We have ensured ultrasound compression 2 to 3 centimeter apart from cephalohumeral junction, so that glue cannot migrate into the venous system. And here applying for 3 seconds. And initially, we have kept in mind, first part it is we have to pull back for 1 centimeter, and again delivered 0.1 cc glue, and then we have to compress initially for 3 minutes for the first segment of GSB occlusion. And after first segment of VENASEALT occlusion, we have to look at the delivery catheter tip under ultrasound guidance. And then again for 3 seconds delivery of 4.1 glue, and pull back for another 3 centimeter, and again compression for sometimes not mandatory for 3 minutes. For subsequent withdrawal of delivery system 3 centimeter, and deliver glue for 3 seconds. Here is the last step. Should compress enough not to migrate glue into the subcutaneous system. This is the puncture site here, showing applying bandage, small bandage. Here conformation is done by doing image, ultrasound image. We are showing the compression of collapse GSB, and this is all about the procedural steps. And now here again I want to mention the proper staphenofemoral junction measurement and keep position, that is 5 centimeter away from staphenofemoral junction. In other endovenous ablation it is 2 to 3 centimeter apart. And the advantage of VENASEALT procedures are eliminates need for immunosuppressive anesthesia, no rates of thermal injury because it is non-thermal ablation of varicose vein, rapid return to normal activities, and no need to post-treatment compression stocking, and no capital equipment needed. And no capital equipment needed means there is no need to buy Covident RFA machine or laser machine, etc. But in every endovenous ablation procedure, we need ultrasound machine. Here are the adverse effects. Allergic reaction to cyanoacrylate glue may have venous thrombosis, 3 to 5% cases. May develop some pain, superficial phlebitis, edema in treated legs, embolization including pulmonary embolism, very, very rare, and puncture site hematoma, hyperpigmentation of skin, infection at the access site. And what are the current disadvantages of classical surgery, that is manual removal of the varicose vein segment from the leg, and regional anesthesia required, long incision scar, post-procedure discomfort and wound care, 2 to 3 weeks recovery, and must need compression stocking. And in thermal therapy, there are some disadvantages also, but very minimum on comparison to classical surgical maneuvers. There may have development of hyperpigmentation, endothermal heat introduce thrombus that may lead to development of complete or partial different thrombosis DVT and have some superficial thrombophlebitis. Very rarely may develop nerve injury and there is no need for compression stocking. And opportunist seek for improvement for by using VENASEALT, we have elimination of emotion anesthesia, procedure compression stocking, and we can reduce thermal related nerve injury. There are some clinical evidence by different study groups, feasibility study, and E-score, VENASEALT, V-close studies. Primary and secondary endpoints in V-close. This is the randomized controlled trial now going on in every aspect. 1 year, 2 year, and 3 year primary patency, that is closure rates is more than around 95%. And another endovenous ablation procedure is endovenous laser ablation. That is the light amplification by stimulated emission of radiation with endovenous, and by using laser of different lengths starting from 810 and latest one is 1980 nanometer. I think there is a mistake, 1940 nanometer. It will be 1940. And generation of heat at the end of laser fiber and damage of endothelial injury by thermal wind. And there are the different machines of endovenous laser ablation by BioLight. And this is the laser emission fiber. And endovenous different equipments, all already mentioned by my previous speaker, Dr. Rakibul Hassan. And here is more or less same steps we have to go for vein mapping and under local anesthesia, GSB, puncture, under ultrasound guided, introduction of femoral sheath and introduction of coaxial laser fiber and Timogen anesthesia. Also, Timogen anesthesia is needed in case of RF ablation. In Pro system here, this is in VENASEALT and mechanochemical ablation, we don't do Timogen anesthesia. And here the varicosities are treated by foam sclerotherapy after ablation of GSB.
Incompetence of the lower limbs by endovenous laser under ultrasound guidance provides a minimally invasive and less traumatic solution. Percutaneous entry is made into the vein at the desired point using a 16. The guide wire is then introduced into the needle and advanced. Later are inserted over the guide wire and into the vein. The adhesive guide wire is then removed and the laser fiber is inserted into the introducer sheath and advanced along its length. The fiber is advanced to a position 2 centimeters below the saphenofemoral junction.
The key point, 2 centimeters apart from saphenofemoral junction in case of venous, in case of laser RFA or in mechanochemical ablation, but in VENASEALT we have to put 5 centimeter apart.
To preserve the integrity of the femoral vein from the first pulse of dilution. This type of anesthesia creates a cushion of water around the vein to protect the perivenous tissue or junction.
Perivenous collapse.
The first pulse of laser energy is delivered. The laser fiber is withdrawn by around 3 millimeters between each pulse of laser energy. To this condition,
This is the showing laser fiber.
the laser fiber is withdrawn around 3 millimeters between each laser pulse. The pulse width of the 980 nanometer Cerilus D laser is adjustable in both length and frequency to achieve the correct treatment parameters with respect to the vein physiology. Incompetence of the lower limbs by endovenous laser under.
And here is the vein mapping. In all types of endovenous ablation, we have go to venous GSB mapping before procedure, just before the procedure in operating theater. And here is the laser emission. And contraindication in endovenous laser ablation, GSB is too close to the skin. Usually dilated GSB, it is said more than 25 millimeter of dia, and usually tortuous GSB having any types of phlebitis and may have complications of endovenous ablation, starting bruise, vessel perforation, hematoma, infections in pigmentation, paresthesia, damage to non-target tissue, and also may have skin burns. And all types of varicose vein intervention modalities are available in Bangladesh. And though it is endovenous treatment, though all types of endovenous ablation are free of radiation, free from radiation hazard. Here is the some picture showing the CME of VENASEALT in Vascular Care Center, SINA Hospital by scientific partner of Mechanochemical. After CME, we did our first VENASEALT procedure in this year, 24th February, under the leadership of our mentor, Dr. Abid sir. The first day we did 2 VENASEALT cases, and subsequently we already did 9 cases of VENASEALT ablation. And thank you all for patience hearing.
Thank you, Dr. Swadesh Ranjan Sarkar. It was a wonderful presentation. Now I would like to take some questions from audiences. Please click raise hand options from your Zoom application. We will unmute you to give your opportunity to ask questions. And we have already, and again, you can put your questions in chat boxes and Facebook live comment section so that we can pick up your questions and seek the answers for you. In this meantime, we have got some questions from our audiences, and I will pick these questions. And our panel of experts and our chairperson, Dr. M. Abdur Rahman sir, commonly will answer these questions. And we have our speakers here too. They will participate in the question and answer sessions. First question is, patients who have varicose vein use compression stockings, but they are uncomfortable. So how can they, it can be comfortable for the patients, please?
Abid sir, শুনতে পাচ্ছেন sir, can you hear us?
Yeah.
This question is asked by Dr. Abdul May. He is a brilliant dermatologist of the country. He has asked, there is varicose vein, but patients are reluctant regarding use of the elastic stocking, as it is to some extent cumbersome. Patient feels discomfort. That is, varicose vein is a disease, but elastic stocking, sometimes it is a disease, sometimes it is not patient friendly. So what will be the answer regarding this question raised by dermatologists?
I think there are two issues. We face the same issue here: compliance. That is an issue with varicose veins. The first issue is the correct fitting. The stockings need to be fitted correctly to have a better compliance. By that, I mean the stocking should be measured in the morning when the leg is least swollen, having the patients keep the leg elevated at least overnight. That I don't mean elevated, at least a few inches elevated from the bed level, wherever they sleep. Then you go first thing in the morning, get the stocking measured. That's the appropriate size. And once that is measured, then you can assume that's the correct measurements, and they'll have a better compliance. It is difficult. It is difficult. There's no question about it. The pressure, again, depends what pressure you prescribe. If it is 30-40, obviously, that will depend on the finding of the ultrasound scan. If the disease is severe, reflux is severe, you're trying to reduce the reflux time with the compression stocking. On the other hand, somebody doesn't have whole lot of reflux, but as a varicose veins, then you can start with the lower compression stockings, compression numbers. That's one. The number two, as I said, it also depends on how severe is the refluxes. That will assess with the ultrasound scan. If it is severe, then you really need to consider getting the interventions for the procedure. We in United States and most of the Europe requires to try compression stockings for months before, particularly the insurance company will approve for the surgical interventions. Although as a physician, you know this patient will require some interventions. It's just the procedural things to go through this to get approval for the patients through the insurance. So in your setting, obviously you don't have an insurance system controlling the parts. It's the understanding between you as a physician and then patient. If you think patient has a long-standing symptoms and they're not going to comply, I don't see any reason to wait for any longer, and the severity of the disease is severe, then you can proceed with the planned treatment. And then, again, you have to, I know you showed the animated video, there's no need for compression stocking, especially VENASEALT they are promoting, but you have to understand the disease as a global process of a person. He or she may have multi-saphenous vein problem. That means the greater saphenous vein, maybe short saphenous vein, or what we call lesser saphenous vein, or the perforators, or the deeper veins. For the stockings, long-term need for the stocking is not necessarily based on just the greater saphenous vein or your ultrasound evaluations limited to saphenous vein. You really need to understand the whole physiological process of the venous system in the leg. If there is if it is significant reflux in the deeper system, yes, patients would need lifetime endurance or lifetime compliance with the stockings. You can't say, I think the company is promoting in the sense I sort of don't agree with that, and most of the surgeons would not agree with that because it depends on the patient's finding on the ultrasound scan. Does that answer your questions?
Okay, sir. না এখানে যেটা স্যার একটা আসছে যে কোশ্চেনটার একটা পার্ট ইজ ইলাস্টিক স্টকিং, এটা তো নট ইজ অ্যাডজাঙ্ক্ট, নট ডিফেন্সিভ ট্রিটমেন্ট. If the patient has got obvious significant reflux in the great saphenous vein, not only the stocking is the treatment, rather patient needs the ablation of the great saphenous vein and treatment of other, like if there is reflux in the perforator veins as well as the short saphenous vein.
Correct. I don't know. It depends on the dynamics of the patients and his or her circumstances. If they say, oh, I don't want to go to the surgery, that the options of, it's not a cure. Obviously, it's not a cure. It's a improvement of the symptoms. If your symptoms, leg symptoms is worse with the compression stocking, you know, that happens because it's a back pressure from the vein when the patient is up and down and stocking, sitting, is a gravity as well as the back reflux pressure. The leg swells up, they have a terrible feeling of the pressure against the stockings. That's understandable. So the stocking is not going to be any good for that patient unless you address the underlying basic venous issue or problem, whatever you call.
Okay, sir. Next question. Next question.
আমাদের কাছে অনেক পেশেন্টই আছে যারা স্যার লং টাইম পার্টিকুলারলি স্টকিং ব্যবহার করছে, বাট দি টেলিং দ্যাট এই স্টকিং ব্যবহার করে তো আমাদের ভালো হলো না বা আমি এটাতে কিওর হলো না স্যার, এটা কিন্তু একটা কমন কোয়ারি পেশেন্টদের থাকে স্যার।
It's not a cure. I mean, because we didn't have, think back 20 years ago, or I think it's 25 years ago, it started the endovenous ablations with the laser. What was the choice? Choice was the surgery. That was limited to the saphenous vein. And there was, and then the surgery had so much comorbidity. So as a surgeon, we didn't recommend routinely for the venous problem to have the surgical procedures. And so that was not the, so in the meantime, the compression came to make the symptoms, improvement of the symptom of the particular patient. That was not a cure. It's just a partial resolution of the symptoms. Or in some patients, symptoms are resolved. That's because they didn't have a severe reflux, physiologically severe reflux.
Yeah, second question.
Okay, Dr. Jubair Ahmed, he asked, may I know which is more preferable, sclerotherapy or hook phlebectomy? মানে কোন মেথডটা ভালো সেটা উনি জানতে চাইছেন, sclerotherapy or hook phlebectomy, sir?
Sir, what will be the tricky answer regarding this, regarding the varicosity? Hook phlebectomy or
I think it's a physician personal choice or the availability. To be frank with you, we haven't done any phlebectomy for 20 years, or the maybe over longer than that, the stripping. Because so many chemicals is available now. You know, all these large varicose veins you're seeing, that's not really a favorable for phlebectomy. We have a called term hook phlebectomy. It makes a micro incisions over the varicose veins and then put the hook and lift it up and then tie it up and then this. But it's still a sort of minimal surgery. The sclerotherapy is not. And now that you have all the choices, you used to have started with the high concentrated saline, was very painful. Then sodium tetradecyl came in, and we found it was painful. But if you make a foam, it's not as much painful. Now we have a commonly going polydecanol, polytetradecanol that is less painful, and you can make a lot of foam of it. And then sclerotherapy is the thing to do with it. So it depends on what's the person, physicians is used to it. If you have used to it, and then acceptance of the patients. Obviously, I know varicose veins is more prevalent in the female. They would like to have a leg without the scar. It probably doesn't matter to the male patients, a hairy leg and doesn't show up. For female patients, they would like to have some cosmetic better results.
স্যার এখানে যে স্টেজ প্রসিডিউর যেটা স্যার এখানে একটু বলি যে বলা হচ্ছে স্যার অ্যাকর্ডিং টু দা লিটারেচার স্টেজ প্রসিডিউর করলে অনেক সময় দেখা যায় অ্যারাউন্ড 75% পেশেন্টের কোনো ভ্যারিকোসিটি আফটার 3 months or 6 months কোনো ভ্যারিকোসিটি থাকে না। for a first time only trunk ablation, followed by follow-up. If there is any residual varicosity, then phlebectomy or sclerotherapy.
That's what we do. But we noticed you guys address I understand your logistic and economical dictate the terms, how patients are being treated. We never do the sclerotherapy at the same time when the ablation is done. You do the truncal ablations, and then, what percentage? I think it's a 10 to 15% people has the accessory saphenous vein and the duplicate saphenous vein. You're forgetting that part. In some population is even about 20%. So even with the truncal, when you do those, see, we expect these varicose veins to reduce in size, and obviously less pressure in the varicose vein on ambulations or sitting from the gravitational force. But if they don't improve, we evaluate with the ultrasound scan, see if there is any, did we miss it? First of all, did we fail to ablate the vein? Second of all, is there any accessory saphenous vein? Third, if there's a duplicate saphenous vein, or is it a problem with the lesser saphenous vein? If those are not there, then we take, okay, now we need to ablate those varicose veins. So I fully understand, and then you guys want to do one shot, one payment for the systems. That's okay. That's acceptable. That's the society accepted. That's doable. But ideally, those are the reasons you should step it.
Okay, Jia, next question.
We have one question from Facebook. Mr. Mirza Alimujjaman wanted to know, is this RFA available in Dhaka? How much does it cost? Is the catheter and heating element reusable? Sir, please.
Now, Dhaka to definitely RFA, all the procedures are available in Dhaka. All the modern technology regarding treatment of varicose vein, যেগুলো আমরা ছবিতে দেখিয়েছি, all are available in Dhaka. Number one, this is officially, this is not reusable. This is the official talking. This is not reusable. This is on time. Everything, laser, RFA, VENASEALT, mechanochemical ablation for on time. This is for on time. Another.
Okay, there is also one comment from him. Yeah, he also commented another point. VENASEALT appears good, but chances of embolism may be there. Do you have any comment about this?
Sir, embolization সম্পর্কে sir regarding VENASEALT embolization or embolization or with other procedure.
Well, 1 ounce of prevention makes how many pounds of cure? This is of utmost importance. I think all the speaker has mentioned the distance from the saphenofemoral junctions of the procedure. I would, even if you go longer than 2 centimeters for the RFA and the laser, there is no reason not to set your procedural ideology to be there. First of all, you guys don't face an issue with the obesity as much as we do. So we kind of make it, if we cannot see the saphenofemoral junctions, we'll make it longer length of, it's not necessarily 2 centimeters, we'll just go 3 or 4 centimeters. And in the same way with the VENASEALT, 5 centimeters, we set up in the office, okay, skinny patients will try to be at 5 centimeters, but if it is always a hard time to see the junctions, and a 3 minutes compression of the VENASEALT is a long time. And especially if a 300-pounder is very hard to hold 3 minutes compression at the junction without having your arm getting tired. So you can enlarge the length. See, all precautions of the distance will prevent any embolizations. Embolization is obviously not going to happen immediately. It happened post-procedures within few hours to few days. So we have that's not never been mentioned. We have a routine thing. We bring the patients back in, repeat the ultrasound scan for two things. One, is it definitely ablated? Because during the procedure, it's very hard to see the vein, and after the procedure it's ablated, you can't see. But sometimes side branches fill in all those things. At least we know for follow-up, we have a status of the follow-up. This didn't close totally, but it may close future. So we bring the patients within 48 hours to 72 hours. That's why we look at the junctions very carefully. If we find there is a clot extended up to the junctions, we put them on a prophylactic anticoagulant for 4 weeks. And then again, before that, we follow that. If there is an issue with the extension of thrombus at the saphenofemoral junction, we follow with another ultrasound scan within a week, see if it's stabilized. If it's stabilized, then we bring them back, the patient's longer period of time for follow-up, see this is stabilized. So far, in 30 years, we never had an pulmonary emboli, but we had extension of thrombus of all the procedures. In spite of all this risk, all the procedures, VENASEALT, laser, RFA, MOCA, had extension of thrombus into the femoral vein, common femoral vein. So we end up putting them on the oral anticoagulant.
Okay, sir. Next question.
I understand.
In all cases, sir, in all patients, oral anticoagulant, sir.
No, people who has the extension of thrombus into the saphenofemoral junctions for 4 to 6 weeks.
4 to 6.
Yeah.
Right. So most important thing is the precaution from the operator's side during the procedure.
Exactly. You can't be casual about this distance. Okay, you have that's the pivotal importance of all the procedures. Distance of the tip of the catheter to the junctions. If you have a hard time to see the junctions, maybe you should abandon the procedure that day. But you need to see it clearly. You need to see it and measure the distance from all the procedure devices tip to the distance to the saphenofemoral junction.
না এইখানে মনে হয় নরেশ স্যার কথা শুনতে পারছেন এইখানে বোধহয় আমাদের একটা মেসেজ আছে যে each and every case after doing the procedure we should do check duplex ultrasound to prove either yes any sort of creation of deep vein thrombosis. There is a question, what is the incidence of DVT in Bangladesh after doing the procedure? Really আমরা তো এই procedure করার পরে একদম ফর্মালি এরকম ডুপ্লেক্স স্টাডি করে যে জিনিসটা আমরা ঠিক এইভাবে আমরা মানে করি না, বাট উই শুড ডু ইট এবং উই শুড মেক এ প্র্যাকটিস যে আমরা পেশেন্টদেরকে এইভাবে ফলো আপ করব. দিস ইজ এ মেসেজ ফ্রম স্যার অলসো ইন দ্য টেক্সট বুকস. জিয়া, অন্য কোনো প্রশ্ন?
Yes, sir. Dr. Mohammad Abdal Mia, he has another question. If patient already develops active venous ulcer, what is the best choice of treatment and what is the outcome?
Sir, he is the dermatologist. They face a lot of patients having venous ulcer, varicosity with ulcer, or post-thrombotic syndrome having ulcer. I think the question is like this. So the ulcer patient suffering, and visiting the dermatologist again and again, sir. Sir, any comment, any solution?
What is the best choice of treatment and what is the outcome?
There is no one answer for that kind of particular patient. This is a problem everywhere. The answer will be detailed evaluations of the patients as to why this ulcer is. If it is a venous ulcer, you still need to make sure there's no arterial component of the ulcer. Because you have given the treatment. If you have provided the treatment to see improvement, hasn't, then you really need to look for other reasons or look for the severity of the disease. So you need to have an ultrasound scan of the arteries and venous ultrasound scan in preference. The venous ulcers are typically not only because of the insufficiency of the superficial and deep system, also big perforators. But you can't jump on getting to the perforator. You have to address the saphenous vein system. If it doesn't heal, given that the patient does have a normal arterial perfusions, doesn't have a complicated diabetic issue, and then you should go for the perforators. So, but if you have given medical therapy, it hasn't healed as you expected, then you should consider extensive evaluation for the patients. First venous, and if there's a predisposing factor for arterial problem, then artery, then jot out the plan of treatment for the patients. It's not going to be a one-time shot. It's not going to be one-time shot on this kind of patients. They are in stages, different stages and different procedures. Obviously, compression therapy is the key.
Sir, এখানে আলসার হলে পরে একটা হচ্ছে আলসার, একটা হচ্ছে আন্ডারলাইং কজ। সো আলসারের একটা আলসার কেয়ার এন্ড ট্রিটমেন্ট অফ দ্য আন্ডারলাইং কজ। আলসার কেয়ার আমরা দেখছি অনেক সময় আলসার কেয়ার নেওয়া হচ্ছে, 4 লেয়ার ব্যান্ডেজ দেওয়া হচ্ছে, পেশেন্ট আলসার হিল হলো, কিছুদিন পর আবার পেশেন্ট স্যার ঘুরে আসছে, রিকারেন্ট ডিউ টু দ্য আন্ডারলাইং কজ। সো আমার মনে হয় যে স্যার একটা হচ্ছে আলসার কেয়ার as well as the treatment of the underlying cause, যেটা আপনি বললেন, great saphenous vein, short saphenous vein, as well as the perforators should be treated.
Okay, I cannot hear you.
আরো কিছু একটা প্রশ্ন ছিল,
জি স্যার।
জি শুনতে পাচ্ছ?
Yes sir, I can hear you.
What is the most advanced procedure?
Yeah,
what is the most advanced procedure regarding all of this?
Yes sir.
Sir, what is the most advanced procedure?
Can you repeat the questions, because I couldn't hear you half a second.
What is the most advanced procedure among all these? RFA, laser, VENASEALT, mechanochemical ablation. Which one is the most advanced?
You cannot, if you just consider ablations, I would go for the VENASEALT, because that's very comfortable, easy procedures. But VENASEALT has its own restrictions or limitations. It has to have because the 5 French sheath goes up there, the size of the vein needs to be at least 3 millimeter in diameter. In that case, when the vein is 3 millimeter or less, then the laser fiber is smaller, or mocha fiber is smaller in size. You can go. This is one procedure doesn't fit everybody, and again the saphenous vein is tortuous. You cannot pass this catheter, so it is easier to pass the laser catheter, especially mocha catheter. It's more flexible and all those things. So it's one pants doesn't fit everybody. It really have to curtail, but you have to decide. So in order to do the procedure, you have to decide a lot of things before you decide what procedure you do. Otherwise, you will run into problem. As you started doing things, you learn this is an issue. You select the patient, selection of the patients for the particular procedure. As I said, VENASEALT is an easy procedure and is tolerable to the patients and goes well. Results are as equal to the other procedure. Then if it was inferior, then it will be different. So I wouldn't put one particular procedure for everybody, because everybody is not going to fit in that.
স্যার পারফোরেটর তো লেজার আরএফএ দিয়ে ট্রিট করা যায়, কিন্তু VENASEALT দিয়ে কি পারফোরেটর ট্রিট করা যাবে?
No. Then you need a mechanical. Then you need again. My preference for the perforators will be the RFA, because I have tried the laser perforators. Their fibers are so small, and it's difficult to manipulate, and it is hard to understand if you are into the perforators lumen or not. But the RFA catheter lets you know there's an energy display on the system that lets you know you're on the lumen. So then you can treat it. The success rate of the perforators ablations with the RFA is significantly higher than the laser.
নরেশ স্যার আছে, নরেশ স্যার একটু এই যে আমরা পারফোরেটর গুলো স্যার যেটা বলছেন, আমরা যখন করি পারফোরেটর কি অ্যাড্রেস সব পেশেন্টের এইভাবে একটা হচ্ছে ডুপ্লেক্স ইভ্যালুয়েশন আর একটা হচ্ছে ডিউরিং ট্রিটমেন্ট আইদার সার্জারি অর আরএফএ অর লেজার অর এনি প্রসিডিউর, পারফোরেটর কি আমরা কেউ আলাদা করে ট্রিট করি না আমরা স্ক্লেরোথেরাপির মধ্যে আমরা এটাকে ফেলে দেই? নরেশ স্যার একটু এই সম্পর্কে রিগার্ডিং পারফোরেটর। হ্যাঁ কি হলো, এটা কি করা নাকি?
হ্যাঁ স্যারকে বলতেছি যে স্যার পারফোরেটর তো বিশেষ করে লেগ পারফোরেটর গুলো আমাদেরকে বেশি ডিস্টার্ব করে। লেগ পারফোরেটর আমরা তো আরএফএ করি বা লেজার করি, সবই তো করি এট দ্য লেভেল অফ দ্য নি, বাট যাদের লেগ জিএসবি ডাইলেটেড থাকে এবং সাথে পারফোরেটর থাকে তখন দেখা যাচ্ছে স্যার আমরা উপরে করার পরেও তার প্রবলেম কিন্তু যায় না। তাহলে আমরা কখন লেগ জিএসবি কে ট্রিট করব, কখন আমাদের পারফোরেটর কে ট্রিট করব?
না কিন্তু সে পারফোরেটর ট্রিট করলো আমরা কিন্তু এটা কি করছি, আমরা মোস্টলি ডিফিউজলি আমরা যে স্ক্লেরোথেরাপি দিচ্ছি থিংকিং দ্যাট স্ক্লেরোথেরাপি উইল গো into the varicosity as well as it also will touch the incompetent perforators as it is diffusely distributed.
No, you cannot expect that. I know to see that's again all the literature say is good enough to ablate the greater saphenous vein just below the knee, but that eliminates the perforators. Hardly any big perforators in the thigh that will affect the leg, the ankle also. There is the 5 perforators in the leg, 3 in the medial compartment and 2 on the posterior compartment, right? Those are the localized high pressure in the superficial system cause the ulcer. So we haven't, if you know with your ultrasound, if you know the ultrasound evaluations, you have to, the venous ultrasound evaluation means you're looking at the perforators and measuring the size and the reflux of the perforators. If you haven't done it, that study is incomplete for the patient because you haven't really globally looked at that patient's condition. And your decision is also skewed because you have not known about the perforators. So once you know about the perforators with the ultrasound scan, so there is a 4 millimeter or 3 millimeter perforators at the time of examination, but physiologically and functionally, that may be even 5 millimeter diameter when the patient is standing, walking, and running. So your aim could be and potentially alleviate that perforator when you do the ablation. So select that location of access just distal to the perforators of the greater saphenous vein. So there are a lot of if and how. All depends on your ultrasound evaluation. Venous ultrasound scan is tedious and time consuming and a very, very technician dependent, or I guess you guys do it yourself. So we have a vascular technicians, they do it routinely. We don't get personally involved with it unless we want to see the patients personally. So the venous duplex scan evaluation is very tedious, time consuming, and needs to be detailed for the patients. Is a garden variety of varicose veins and the discomfort for the patients, you may not need it. But patient with the venous ulcer, recurrent ulcer, or stage 5, C5 or C4, that patients needs to be greatly evaluated in detail.
Jia, amra already it is 11:20 p.m.
Can we take another 1 or 2 questions?
Okay, another 2 questions.
Okay, Dr. Ankon Kumar Paul asked, if the varicosities are confined to the only short saphenous vein territory due to incompetence of saphenopopliteal junction, either symptomatic or asymptomatic, then what will be the suitable treatment modality?
Sir, only involvement of the short saphenous vein, sir. Reflux as well as in the short saphenous vein. Saphenopopliteal junction incompetent. Sir, শুনতে পাচ্ছেন
Did you say symptomatic?
Yes, sir. Yes, sir.
Symptomatic.
Yeah,
asymptomatic
you treat it. If you
it's
find that, yeah, you have to address that. If a patient is symptomatic, you have to address that and try to go for ablation of the lesser saphenous vein. And if that doesn't resolve the symptoms, then for sclerotherapy. And at the same time, you do the greater saphenous vein and other deep venous system. If the symptom, unless it's a complicated ulcer, recurrent ulcer, dermatological changes, you're just trying to treat patient symptoms. If you find is localized in the short saphenous vein or greater saphenous vein, treat that segment and then wait. Even if you find reflux in the greater saphenous vein, you don't have to really go after that. Again, that will depends on the patients. Say we ablated lesser saphenous vein, and patients come back with the aching, discomfort, heaviness after walking and standing, then you know he was symptomatic from greater saphenous vein. You need to go after that.
Sir, latest 2020 update regarding the varicose vein treatment from the American VENOUS.
তোমার কথা একেবারে ভাঙে ভাঙে আসতেছে।
And other societies also, short saphenous vein or perforator vein. Sir, the recent guide is published in 2020. They all recommend treatment of symptomatic great saphenous vein incompetent perforators. When patient is symptomatic, it should be treated.
Right. That's what I said. And no, even the question was, is a lesser saphenous vein, the reflux and is thought symptoms are from lesser saphenous vein, you'll treat that. And obviously you'll plan to treat that and do the ultrasound scan. You find there about a 1 second reflux in the greater saphenous vein. Leave it alone till patients complain again. Then you can treat the greater saphenous vein at that time.
Okay, sir. Yes, sir. Thank you, sir, for the nice question and answer session. We have learned a lot of things from this session. Our distinguished guest and panel of experts have answered lots of questions. Now we are near to the end of our webinar. Now I request Honorable Chairperson of today's webinar, Dr. M. Abdur Rahman sir, to say something for us, please. Dr. M. Abdur Rahman sir.
Since the topic is about the veins, as was introduced, about 30% of the world population has a venous problem, and that has been addressed all these years. That's because, as I mentioned, the procedure was available, was associated with the significant morbidity, and surgical intervention was not acceptable to the society as a whole. Now that we have endovenous ablations, other modalities, this procedure should be a little more easily accepted by the physicians and present to the patients more often, and that will benefit the society as a whole. Even though we think venous disease is not that serious, it is. It is causing a lot of discomfort and a lot of limitations of activities of the people who are really everyday's worker earning their livings. That hinders their activities. And especially it ends up being an ulcer. That is a serious complications. I think we need to educate the physicians in general. Yes, this is an issue in the society. We need to continue to promote that. Not necessarily for the professional benefit, it's for the society benefit as a whole.
Yeah.
Yes, sir. Okay, sir. Now it's time to express our thanks and gratitude to all our participants. Lots of doctors and dental people also participated to this webinar. I will request Professor Dr. Naresh Chandra Mondal, Professor and Head of the Department of Vascular Surgery and ACBD, to say something about today's webinar. This is our closing speech with the speech from Professor Naresh Chandra Mondal. Our webinar our webinar will be closed for today. Thank you. Professor Naresh Chandra Mondal.
A good discussion. Many thanks to our respected teacher, Dr. M. Abidur Rahman, joining for USA, and also thanks to the learned participant to this session. And thank you everybody.
স্যার আমরা তাহলে এখানেই আজকের